So just an introduction. Laryngomalacia is the most common cause of noisy breathing in infants. And it's characterized by prolapse of a supraglottic tissue into the glottic inlet with inspiration. And most laryngomalacia would resolve spontaneously by 18 months with minimal, with conservative management or just medical management. Only a small percentage would require surgical management via supraglottoplasty, which would be the first choice. So just looking at types of laryngomalacia, there's 3 types, and the different types can occur together. So with type 1, there's redundant arytenoid mucosa that's prolapsing into the glottic inlet. With type 2, there's foreshortened arterioglottic folds bilaterally. And with type 3, there's a omega-shaped and posteriorly displaced epiglottis. Associated conditions, gastroesophageal reflux disease has been reported in 50 to 90% patients with laryngomalacia. Sometimes there's neuromuscular disorders associated with laryngomalacia. They generally carry a slightly poorer prognosis. Some genetic syndrome to keep in mind is Dye-George syndrome. And then one must also think about synchronous airway lesions. So 15 to 30% of children would have a synchronous airway lesion. So any features that's clinically not in keeping with laryngomalacia will need further investigation, like biphasic stridor or hoarseness. And then also some studies reported prematurity as a risk factor for laryngomalacia. Just a brief overview of the pathophysiology. And central to the pathophysiology is airway collapse that causes turbulent flow in the stridor. The airway collapse causes increased work of breathing, or increased intra-abdominal pressure, and then worsening reflux. This in turn increases airway edema, and then that decreases the airway diameter. And associated factors are poor neuromuscular control. This poor neuromuscular control is also at the level of a lower esophageal sphincter. And that's why PPIs are quite central to the management of laryngomalacia. Diagnosis is made on clinical history and been confirmed with flexible nasal endoscopy. No imaging is generally required. Severity grading, and we use a Thompson classification that classifies into mild, moderate, and severe, with mild and moderate accounting for 80% of patients, severe for 20% of patients. These are generally the patients that require surgical management. So a mild subclass is defined by intermittent stridor, normal oxygen levels, normal feeding, and normal growth. Moderate has got persistent stridor at baseline, but normal resting oxygen saturation. Parents often report that the baby tired during feeding, and they sometimes have some coughing and choking and postprandial emesis. These babies are normally of normal weight with then a history of weight loss. And in the severe subtype, they classified by apneas, failure to thrive, crossing centiles on the growth charts, aspiration, low oxygen saturation levels, and severe features of airway obstruction. Indications for supraglottoplasty can be classified into primary, secondary, and tertiary, with primary being severe airway obstruction, especially sleep-related, and a definite indication would be with an apnea-hypopnea index of more than 10 on overnight oximetry or polysomnography. Failure of medical management with severe symptoms, so severe subtypes of it's not responding to medical management, and then failure to thrive with children crossing centiles also a primary indication. Secondary indications are dysphagia, apparent life-threatening events with cyanotic spells, if all other conditions are excluded that can cause cyanotic spells, and then worsening of comorbid conditions. The child has underlying neurological or cardiac or respiratory conditions, plus worsened by the laryngomalacia. Tertiary indications are persistent stridor that's worrisome to the parents, but there's no features of significant airway obstruction. And then a very soft indication would also be recurrent respiratory infections. Contraindications are pretty obsolete, but it's in brackets because it's not generally a rule, but active infection, certain synchronous airway lesions of the lower airways, like tracheal stenosis or subglottic stenosis, distorted anatomy that can, some craniofacial syndromes. And then relative contraindications would be uncontrolled gastroesophageal reflux disease, but sometimes one needs to do the supraglottoplasty to aid in the management of the gastroesophageal reflux disease, poor nutritional status, prematurity, and coagulopathy. So preoperative considerations, one has to document the vocal cord movement prior to proceeding to supraglottoplasty. Management of other levels of obstruction is also important. So one needs to look for adenoid hypertrophy and rhinitis that could also contribute to obstruction. And those have to be managed either concurrently or prior to the supraglottoplasty. Management of comorbid gastroesophageal reflux is quite important. So all patients with moderate and severe laryngomalacia should be on a PPI. They should have a counseling on upright feeding, possibly thickened feeds, and allowing enough time for the baby to feed. Polysomnography might be indicated in some patients with significant sleep symptoms, but to note, just there's reduced reliability of these investigations in infants. Swallowing evaluation needs to be done. This can be clinically to look for aspiration and dysphagia, usually done in conjunction with a speech therapist, and then a team decision can be made if FEES or a video fluoroscopic swallow is indicated. As some of these patients are crossing centiles and losing weight, their nutritional optimization is also important. So involvement of a dietitian, and then possibly the use of hypercaloric feeds if infants that's only managing to get in little amounts of feeds. One of the other points to look at is timing of surgery, and they're generally classified as early or late surgery, and that's early would be before 6 months of age, and late would be after 6 months of age. So advantages of early surgery, you prevent long-term complications, there's rapid resolution of severe symptoms. They've got a bit of a lower success rate than late surgery, 85 to 90%. They do have a higher complication rate, and revision rates are about 10 to 12% compared to revision rates for late surgery, which is 5 to 8%. Risks, there's an increased preoperative risk due to airway size in the smaller infants. And then advantages for late surgery is reduced risk of complications, and because of older age, we've got an improved tolerance for anesthesia, and it's generally a much safer and easier anesthesia when they're a bit older. But the risk of doing delaying surgery is prolonged failure to thrive, and some issues of developmental delay that can have some long-term sequelae. So just a few factors with timing of surgery that would push one to do it earlier rather than later, with sleep disordered breathing with apnea-hypopnea indexes of more than 20 and desaturations below 85%. Uncontrolled gastroesophageal reflux disease that might be worsened by the presence of laryngomalacia, and then weight gain and growth. Once the child reaches below the 5th percentile for age, one just need to strongly consider surgical management. At Red Cross, we prefer to do supraglottoplasties on infants older than 6 months and more than 10 kgs, as there's less perioperative complications and there's a larger airway that makes surgery easier. So techniques that's been described is the most commonly used cold steel, about 90% of cases. Then CO2 laser microsurgery, about 10% of cases. Then some studies have reported on microglobrider assisted supraglottoplasty, and then of late the coblator is also being used for supraglottoplasties. Just of note, with all these techniques, there's equal outcomes for the different techniques, and no technique's been shown to be superior. At Red Cross, we prefer the cold steel via endoscope approach because there's less long-term risk of supraglottic stenosis. Just looking at the advantages and disadvantages. So for cold steel, it's relatively precise, very cost-effective, with low cost of equipment, but disadvantage would be a high risk of bleeding. With laser assisted, you get minimal bleeding and an enhanced field, as there's less instruments in the field, but thermal injury and cost are disadvantages. And with microglobrider assisted, it's just a big risk of trauma to the airway should the instrument slip. Subsites that is being operated on during a supraglottoplasty is the area-epiglottic fold release. That's done in a majority of cases, close to 95%. And then excision of a redundant arytenoid mucosa, done in about 60% of cases. Partial trimming of the epiglottis or epiglottoplasty. Percentages haven't really been reported. And then epiglottopexy, which is only about 7% of cases, but reserved for most severe cases, but not responding to the prior techniques. So at Red Cross, we try and avoid epiglottopexy as far as we can, because it's associated with quite bad aspiration. In this diagram, it just shows on the left, the red shaded areas is where one would remove mucosa to release the epiglottic folds and remove some of the redundant mucosa. On the right, just two pictures demonstrating before and after during surgery. So just looking at outcomes, the overall success rate is about 85 to 95%. So good overall outcomes. Has been shown to improve quality of life scores for both infants and caregivers. Significant improvement of apnea indexes has been reported post-surgery to below 10 in most cases. Persistent stridor is only in less than 5% of cases, and the re-intervention rate is only needed in about 5 to 10% of cases. So just looking at complications, so intraoperatively, about a 5% chance of bleeding, and post-operative edema. Sorry, that should have been under post-operative. Is also around 5% with stridor or hoarseness. And then post-operatively, bleeding is one of the complications immediately, as well as post-operative airway edema. And the short-term aspiration, which is usually transient in about 5 to 10% of cases, and lasts about 2 weeks to a month. Late complications is granuloma formation in about 1.1 to 2% of cases. The most feared is a supraglottic stenosis, and then persistent stridor, like I said, in less than 5% of cases. Just management of complications, bleeding. We usually just use adrenaline-soaked pledgets to control the bleeding. Aspiration That's usually done in conjunction with our speech therapist, but we use pick and feeds and positioning while feeding, and then in certain kids, nasogastric tube feeds until they're not aspirating anymore. Persistent stridor. Once this is encountered, one is to exclude a secondary airway pathology and consider revision surgery if a second airway pathology has been excluded. Granuloma formation, one can just observe him and give him some steroids, rescope him in a few weeks and see if it improves. Otherwise, if they're poorly responsive to conservative measures, one can do surgical excision. So just in terms of post-operative management after theatre, monitoring, so most patients at most centers will go into a monitored bed, either in a post-anesthetic high care unit or ICU. Usually patients are extubated on table, and then in the ICU it will just be continuous monitoring of saturation, respiratory support as needed, and then just monitoring of sedation levels. Oxygen ventilation, so usually one would like to maintain an oxygen saturation of more than 92%, and use non-invasive humidified ventilation as per your institutional protocol. Positioning, we prefer patients with the head of bed elevated to 30 to 45 degrees to reduce airway edema, and to nurse them in a lateral position to allow for clearance of secretions, and they're just more comfortable in the lateral position from an obstruction point of view. Pain and sedation management. Usually there's mild to moderate pain, which can be managed with acetaminophen and ibuprofen. Trying to avoid opiates because of a potential for respiratory depression. And then I've got another slide on dexmedetomidine, which I'll go into a bit later. Airway management for post-operative edema, the use of corticosteroids, nebulized adrenaline as needed, and emergency airway equipment should be available where the patient is nursed post-operatively. Aspiration risk, like I said, frequent feeds and nasogastric tube feeds. Most patients will be either on a proton pump or inhibitor or H2 blocker post-surgery to reduce gastroesophageal reflux, which can irritate the airway, cause inflammation and edema, and it can also lead to delayed healing and granuloma formation in the long run. Antibiotics is prescribed by some institution to prevent secondary infection. And so just on our approach, the setup, we have our complete setup ready before the patient's induced. For anesthesia, this will include the appropriate size and Benjamin Lennon laryngoscope with side port ventilation, appropriate size Hopkins rod telescopes railroaded with a rescue airway of appropriate size for patients' age and weight. We'll have a total dose of lignocaine ready for topicalization of an atomizer, adrenaline soaked pledges for managing bleeding, and then suction. Once the whole setup is complete, patient will be induced, and then positioning of the patient will be with an anesthetic machine close to the head of the bed as per shared airway protocols. Patient will be in a supine position with a shoulder roll and the head stabilized with a head ring. On induction, there should be a clear plan between the anesthesia team and the surgical team, how to manage the airway and the sequence of events. So here, what most often happens would be a gas induction, after which there will be placement of IV line, and then a patient will be bag mask ventilated while being transitioned to a total intravenous anesthetic. We prefer tubeless anesthetic where possible. After that, patient will receive prophylactic antibiotics in the form of methazoline, and patient will get an intraoperative dose of dexamethasone. So like I said, we prefer tubeless anesthetic and to have the patient spontaneously breathing initially. We use sideboard ventilation, and we do intermittent intubation as needed. If a patient does not tolerate sideboard ventilation, we do our supraglottoplasties with a tube in situ. And then we prefer titrated propofol dexmedetomidine infusion anesthetic. And so surgical technique, for us, we do an endoscopic airway assessment to rule out synchronous airway lesions at the time if this hasn't been done prior. We actively exclude a laryngeal cleft. We topicalize a surgical site, followed by decongestion with adrenaline pledgets. And then we perform cold steel technique with trimming of bilateral A folds. And then we'll do a one-sided trim of the arytenoid mucosa and see how that improves the airway. And then we'll do an epiglottoplasty, trimming the lateral edges of the epiglottis if needed. In a staged approach, we try and avoid injury to the cartilage as much as possible. And then we avoid trimming the medial surfaces of the retinoids to prevent interretinoid scarring. For us, transfer to the ICU post-operative is critical, so all our patients are admitted to ICU for airway observation. Patients are extubated on table, and once stable, initiated on high-flow nasal oxygen, which is initiated in the operating theatre prior to transfer to ICU. We prefer the dexmedetomidine infusion for transfer. In ICU, patients are generally kept in ICU for 24 to 48 hours. We prefer patients to be on non-invasive ventilation, at least for the first 24 hours to stent the airway and prevent respiratory distress. We ask for head of bed elevation in ICU. We give dexamethasone for the first 24 hours. We'll give Silodex nebs to most of our patients to improve healing and prevent granuloma formation. And this is very important if there's exposed cartilage, when the patient will have to complete 5 days of Silodex nebs. The patient needs to be properly sedated to avoid straining of the airway to keep them comfortable. We place all our patients on NG feeds post-operatively for at least the first 24 to 48 hours. And then we escalate to an oral diet as per speech and language therapy. And all our patients receive a proton pump inhibitor. Reasons why we prefer dexmedetomidine: it's a controllable titratable sedative. It maintains spontaneous breathing, which intraoperatively allows for dynamic assessment, and in ICU allows for spontaneous ventilation. It's got good analgesic properties. It's opiate sparing. It blunts the stress response. It causes minimal airway secretions and is anxiolytic. So discharge criteria: usually our patients get discharged on day 3 or 4. They must be weaned from any ventilator support, maintain an oxygen saturation of more than 92% on room air, and they need to be transitioned to a full ward diet. But sometimes there's patients that prior been feeding with NG feeds, and they'll continue with NG feeds on an outpatient basis. But this is usually guided by the speech therapist, which would be managing the patient from pre-operative period. A follow-up, so we see our patients 2 weeks post-op. We do a F&E document healing of a surgical site. And then 1 and 3 months, we look for resolution of symptoms, do a F&E to exclude complications like granulomas and stenosis. We'll wean the patient then from a PPI if feeding difficulties and aspiration has resolved. Ongoing monitoring of weight gain. We'll also screen the patients for persistent airway symptoms. If there's persistent airway symptoms, the patient most likely need a combined airway assessment with pulmonology, will include a full DLTB and a flexible bronchoscopy. Alternatives to supraglottoplasty would be nasal CPAP for sleep-related symptoms, and then tracheostomy is reserved for patients with severe aspiration. Usually, these are patients with associated neurological conditions, associated subglottic or tracheal stenosis. So there's multi-level airway obstruction. This allows for staging of surgical treatments, and then associated pharyngomalacia. These are usually also in patients with associated neurological conditions. So in conclusion, supraglottic safe surgical procedure with good outcomes, and standardized perioperative care ensures good outcomes for patients. That's the end. Thanks.
Thank you very much, Jaco. Is there any comment?
Yeah, I've got two questions. One is, so why should nasal CPAP work for a laryngeal pathology? I can understand that it can work with pharyngeal pathology. We've tried to distend the pharynx, but I'm just puzzled by how nasal CPAP would expand a laryngeal airway obstruction. Or do you think that these are perhaps the patients respond to nasal CPAP or might actually have multi-level obstruction, and the problem isn't really at the laryngeal level?
I think, yeah, these are most likely patients with multi-level obstruction, most likely some pharyngomalacia, but associated with laryngomalacia as well.
Yeah, and the next question I have is that if you're using a high flow nasal oxygen post-operatively, here you talk about obstruction rather than the other issues. So do you think you might be masking hypercapnia in the post-operative period by using high flow oxygen? I can understand that you use it intraoperatively, but I'm just worried that if you don't monitor the CO2, that you might be masking, or you might be missing the hypercapnia in the ICU situation.
So these patients are generally managed by the ICU team, and I think the hopes are that they monitor the respiratory and the work of breathing and the respiratory rate. But yeah, one might be concerned that they might be hyperventilating. We haven't encountered a problem of retained CO2 in the patients we've done recently. So I'm not sure, Prof, but yeah, we haven't encountered any problems with a high flow nasal oxygen and retained CO2. But we haven't actively monitored.
There's a big area of contention in the post-op period, even in adults. That the focus is always on oxygen, but not on the CO2. Matt, am I right? Is it becomes obstruction?
Yeah, I think the concern when there's ongoing obstructions, you always retain CO2 and drop your sats very late, even out of the context of high flow oxygen. So I guess that would be a concern. I mean, they do monitor CO2 in the Red Cross ICU by blood gas, and I'm not sure, do they use capnography? I don't think so.
Blood gas. Yes, I'm just wondering why you give option at all in the setting, because I say you could address the problem. So it'd be something just to ask them, because here we're talking about obstruction, we're not talking about.
I suppose it may also give you a false sense of confidence in the patients to walk as well.
That's right. That's right. So it might just be interesting to ask them, ask the ICU team about that, and whether you're actually tracking the wrong parameters in these patients, and you might be getting a false sense of security. So I can understand why you do it at the time of intubation and so on, because you're buying yourself time if you have a difficult intubation. But I'm just, I'm speaking as a non-ICU person, but it just would seem a bit, I'm not sure that it's the right approach.
Yeah, I'll chat to the ICU staff, Prof, and just ask
Yeah,
them.
I'd be interested to know. Yeah.
Okay, thank you, Prof. Dennis, we can see your contribution on the chat. I think everyone can access that. I think, Jaco, the silent features of Dennis' comment is about the comparable results regarding the different treatment modalities. It's quite a long contribution, but I'm sure everyone can read it. Anyone else who has a comment? I see Isaac, you're on the call. I see Butle as well. Anyone else with a comment?
You didn't have to comment on my questions.
No, I don't have any comment. It's like a comprehensive presentation delivered by Jaco. Yeah, thank you, Jaco.
Okay, thank you.
Thank you.
All right, thank you, everyone. Thanks, Jaco.
Yeah, a good overview.
Okay.